Welcome to a special presentation of On the Beat. I'm Troy Thompson. Cancer of the colon and/or rectum is commonly referred to as colorectal cancer, the fourth most common cancer in the United States. More than 145,000 new cases of the disease are diagnosed each year. Now, only lung cancer accounts for more cancer deaths than colorectal cancer. Incidents of colorectal cancer have declined dramatically in recent years. Now, colon cancer and rectal cancer are linked together because they share many characteristics, symptoms and treatments. 2/3 of colorectal cancers are colon cancer. Now, joining me in the studio today to discuss this and more detail is Dr. Richard Hurd and Dr. Ricky Johnson from Gastroenterology Associates of Columbus. Welcome to the show, my friends.
Thanks, Troy.
Let's just refresh everyone's memory what colon cancer is, or colorectal cancer.
Yeah. So in the last bit of your intestine is the colon. And quite simply, colon cancer is colon and is cancer in that part. Your DNA replicates itself millions and millions of times throughout your lifetime. And occasionally, through those millions of times, it'll make little tiny mistakes. And when it makes those mistakes, occasionally, it can flip on a switch where these cells just grow and grow and grow and grow. And that's how cancer forms. So,
by you saying that, I would assume it is also hereditary.
Yeah, definitely. There's a hereditary component to it. Now, you have to be careful saying that because not just people who have a family history are at risk. Everybody's at risk.
Right. Well, now you're saying it can and cannot be hereditary, correct? Who is at risk, doctor?
In general, really everybody is, particularly when you get to a certain age. That's why we recommend screening for the entire population, because we really can't, with confidence, say who will get it and who will not get it. So in general, everybody is at risk. That risk increases with age. Generally, once you get to above your 50s and mid 60s, I think the average age of diagnosis is around 67. Now, certain populations are at higher risk than others for whatever reason. African Americans are a little bit higher risk, so we start screening them at a little bit younger age. There's also things that people do to themselves that make them at higher risk. People who smoke, which is interesting because a lot of people attribute lung cancer mainly with smoking, but smoking actually increases your risk of lots of cancers, and in particular colon cancer, but also obesity, being diabetic, sedentary lifestyle, and then we talked about family history. So those are some things that raise your risk.
Okay. How important is it to listen exactly to what doctor's saying and making those life changes, and will that decrease your risk?
Yes, absolutely. I mean, if you live a healthy lifestyle in general, that obviously is going to help your overall general health. But if you avoid these are what we call modifiable risk factors. If you avoid those, then you're doing yourself a big favor.
Yeah. I got you. Is it different for men and women? Because I know there are a lot of medical issues that come up if you're a gal, for example, and you're at higher risk for things. Right. We talked about being African American. Mm-hmm. Is there a difference when it comes to the cancer?
There actually is a higher risk in men, and we don't completely understand that either. And we talked about the formation of colon cancer, but I think it's important to remember that all cancers, most cancer at least that we treat, starts with colon polyps. And we know that the incidence of colon polyps is generally about 10% higher in men than it is in women. So I usually tell people about 35 to 40% of men that we do a colonoscopy on will have a polyp, whereas about 25 or 30% of women will have polyps. And so that will confer cancer risk beyond that.
Okay, now you just brought up the colonoscopy, and I do want to discuss, you did say men are at a higher risk. Why is that? I would assume because they're not wanting to have colonoscopies?
Well, not necessarily. I mean, we don't understand entirely why men are at a little bit higher risk. But even as Ricky was pointing out, I mean, they have more polyps. So there's something about men's DNA that predisposes them a little bit. The important thing to know there, though, is that doesn't really bear out clinically and in practicality because we don't change screening guidelines. If you're a man or you're a woman, you need to have your colonoscopy and follow these same guidelines.
All right, let's talk a little bit about treatment options. Now, later in the show, we're going to see some procedures being done, but I want to touch on, it's become, I don't know whether it's a craze, people having at-home diagnosis themselves. Where do you sit on that?
With regards to the home testing?
Yes.
There's a a mixed opinion about that. You know, obviously we perform colonoscopies, and we feel like that's the best test to be done to screen for, and more importantly, to prevent colon cancer. And I think that's what's important to remember too, is what we do affords the ability to prevent at the same time you're screening. So there's some non-invasive tests out there that may be effective, but I think none of them are as effective as what we do.
Okay, I want to break that down a bit if I can, because a colonoscopy is a form of screening, correct?
Yes.
But how do we know we need one if we don't have any preliminary testing done first?
Yeah, so this is why we have screening guidelines. You know, the guidelines say exactly when to start. For just about every individual, they fit into some box. And it's not based on a preliminary test. This is what's important for people to remember. It's not based on a symptom that you have or some abnormal test that you have. And a normal individual walking around age 50 can have colon cancer and not know it, not have any abnormal test at all. So this is why we call it a screening test. This is why it's important to do so you can catch it early.
We quote 1 in 20 as a lifetime risk for colon cancer. I think that's important for people to remember. 1 in 20 it's not a small number. I mean, it's a high risk.
It's high risk. Appreciate it. We'll be back after this short break.
Gastroenterology Associates of Columbus and Starkville is here to help. From needs as simple as a routine colon cancer screening to the most severe gastrointestinal disorders, our board-certified gastroenterologists want patients to be informed decision makers and fully understand any health issues they may face. When you choose Gastroenterology Associates, you're working with professionals who are qualified, experienced, and caring. Call our offices today for an appointment or visit our website, gac-ms.com.
Since the mid-1980s, the colorectal cancer survival rate has been increasing due to in part to increased awareness and screening. Welcome back to a special presentation of On the Beat. I'm Troy Thompson. Colorectal cancer, or cancer of the colon or rectum, first develops with few, if any, symptoms, although there may be some early warning signs. Joining me today is Dr. Richard Hurd and Dr. Ricky Johnston from Gastroenterology Associates of Columbus. Welcome to the show, my friends.
Thank you.
Okay, let's talk about the symptoms. What are they?
Importantly, as you alluded to in the lead-in, there may be no symptoms at all, and I think that's very important for people to remember, is that colon cancer in the early stages may not cause any symptoms at all. You could have it and not know it, but some of the reasons that we see people more commonly complain of rectal bleeding, perhaps a change in bowel habits, thinning of the caliber of the stool. People will come in and describe like a pencil-shaped kind of stool, abdominal pain, bloating.
So something to point out here. I mean, these symptoms are all very common. I mean, how many of you?
It's true.
Yeah, how many of you have had bloating before, or change in your habits?
You change your diet, and then all of a sudden you may have some of those symptoms, right?
Yeah, this is exactly why you can't just base it on symptoms. You have to go by these screening guidelines.
Well, can you just explain some of those guidelines again for us?
Generally, age 50 is the time to start. American Cancer Society has just said that age 45 for most people is the way to start, for African Americans, for everyone. If you have a family history, you start sooner. You want to start 10 years sooner than your relative was diagnosed with colon cancer.
Okay, well, we're going to show some footage in a moment that I came to you and we were talking about this, that my father had just recently died of colon cancer. And I'm not at the age where I would be worried about having a colonoscopy. Why was it important for me to have that?
We don't understand exactly why colon cancer occurs, but one of the things we do know is that people who have a family history are at higher risk. And so people who are at higher risk, you want to get them in at an earlier age when you have your best opportunity to intervene and prevent them from developing cancer later in life. So that's why we start screening earlier in people that have a family history.
Now, family history, is there an age when one should be having it?
Yeah, so let's say your father was diagnosed at age 38, you start at age 28. You guys start 10 years before them because that lead time is very important. Also, there's this phenomenon that we see where it happens earlier and earlier with successive generations.
Now, if they were older than 50 when they were diagnosed, say 60 or 65, then you would still start at 40. So we wouldn't go past age 40 in somebody that has a first-degree relative that was afflicted. If you start talking about second-degree relatives, aunts, uncles, grandparents, that doesn't affect your risk quite as much as a brother, sister, or parent.
Well, as you know, we're just about to see what I had done, but one of the questions I wanted to ask both of you was the prep. Everyone seems to complain about the prep.
Yeah, everybody says that's the worst part of the whole
Yes.
thing. What do you think about
Can
it?
I be honest with you? It didn't faze me at all. And it was the night before, as you advised me to
Right.
do, and it was a pleasant drink. You know, I was just uncomfortable for maybe a few hours.
We don't hear that it was a pleasant drink very often.
Well, it wasn't horrible.
But we do hear more common than you would think that it wasn't as bad as people expected. The whole experience was not quite as traumatic as they were anticipating.
There are newer preps now that are easier to drink than back a long
Yes.
time ago when people remember having.
The important thing to remember is when we do the prep for a reason. When we get in there, we want it to be as absolute clean as possible. People would sometimes be surprised at how clean it gets, as we'll see in your case. But if you think about any residual stool left behind, that could block our view, even of a small polyp. So it's really important to get it as absolutely pristine as possible.
So we actually filmed me having a colonoscopy. Let's take a look.
Yeah, what Dr. Johnston just did there was he went to what we call narrowband imaging. It changes the color spectrum of your light that we use, and it helps polyps and other things to stand out. Helps you differentiate maybe some benign things from some precancerous things.
That could be a little polyp right there. So you get a little of these follicles and glands in the colon, and that are benign, but that might be an early polyp. So we'll go ahead and remove that with a biopsy forceps, large forceps. And so Karen, our tech over here, is getting our instrument. We have a couple of different ways that we remove polyps. Smaller, flat ones like this we remove with these biopsy forceps that all pass through the channel of the scope. And they have a little cup on the end that opens and closes with a serrated edge that just basically takes a bite. That's what we kind of loosely refer to this as taking bites. So we'll open the snare and then the biopsy forceps. All right, close. And then we just kind of pull it off. And then I always want to make sure we got the whole thing removed. And it's not, we see a little bit of oozing with this. Well, it looks like the polyp was fully excised. And that bleeding will stop spontaneously after a couple minutes. Go ahead. Just like if you cut your skin, your colon will stop bleeding too.
The important thing to remember is that this is all very magnified. The end of those biopsy forceps are just millimeters, so that looks like a lot of blood, but it is not.
Yeah.
We're going to discuss more of my colonoscopy after the break.
Gastroenterology Associates of Columbus and Starkville is here to help. From needs as simple as a routine colon cancer screening to the most severe gastrointestinal disorders, our board-certified gastroenterologists want patients to be informed decision makers and fully understand any health issues they may face. When you choose Gastroenterology Associates, you're working with professionals who are qualified, experienced, and caring. Call our offices today for an appointment or visit our website, gac-ms.com.
The 5-year survival rate for colorectal cancer found at the local stage is 90%. The 5-year survival rate for colorectal cancer found at the regional stage is 71%. The 5-year survival rate for colorectal cancer found at the distant stage is 14%. Welcome back to a special presentation of On the Beat. I'm Troy Thompson. Joining me today are Dr. Richard Hurd and Dr. Ricky Johnston from Gastroenterology Associates of Columbus. And of course, we are joined by one of their success patients, Libby. Welcome to the show, my friend.
Thank you.
Okay, let's talk a little bit about your case to begin with. At what age were you, Libby, when you first realised that you needed to have a colonoscopy?
Well, I was 70, but I wasn't going to do it. I'm not having any symptoms, and I don't want to go through this anymore. So my good friends said, "You need to do it." I said, "Nah." So I called them up and told them I wasn't doing it. And then after my friends got to talking to me, I called them back and said, "Yeah, put me down." So thank goodness I did.
Okay, well, you've said thank goodness, and I've said you're a success story. Can we talk a little bit about her case to begin with?
Yeah, came in for routine colonoscopy, no symptoms at all, right, Miss Libby? So, you know, again, we were talking before about symptoms and how it's important not to go by that. She came in for her screening like she was supposed to, and saw a mass in her colon when we did this. Of course, the doctor at the time has a suspicion that that's what this is, just looking at it, but they take biopsies.
Okay, so let's just break that down, can we? Doctor, you go in for the colonoscopy, you discover polyps.
Right.
At what stage are you determining whether Libby has cancer?
After it's been removed, it has to be sent off, and a pathologist actually looks at it under the microscope at the microscopic level. So that's
Okay.
how you would determine the stage. I mean, most polyps that we take out are just precancerous, but
Right.
we do occasionally find polyps that have actually started to develop cancer within the polyp itself.
Libby, I have to say to you, when I had my colonoscopy, and all I thought about before I got here was, I don't want to know what happened and if I had been diagnosed with cancer. What was your thoughts going into that procedure?
Well, I thought I was going to go in there and it was going to be done and I was going to go home, or I was going to Cracker Barrel and get breakfast. Or, you know, I was just shocked when he said, "You have a cancer."
When you
So-
say shocked, what was going through your mind?
Well, I didn't know. I thought, wait a minute, this isn't supposed to happen to me. I'm healthy.
Okay, Doctor, 70. Is this what we hear?
Well, 75 is actually cutoff time, but the you know, even that number is a loose number.
Yeah.
If you're, you know, you're 80 years old and you're running a marathon and you have a family history of colon cancer, we're going to recommend that you have your colonoscopy. So it's important to discuss that with your doctor to decide when's the right time to stop.
We talked earlier about guidelines about what age you start doing this, and as Richard suggested, there's guidelines as when to stop, and that kind of differs between different organizations. Some people say that between 75 and 85 is kind of a gray zone, and it really should not be done that frequently. Some of our societies that, you know, tell us what to do as gastroenterologists say that there really shouldn't be an age cutoff, that it's an individualized decision
Yeah.
based on somebody's overall health, how functional they are, what is their life expectancy, because I mean, if somebody can walk into our office at 82 and they're in great health, there's a good chance they're going to see 95. And we have an opportunity at that age still to prevent cancer from happening 10 years down the road.
I got you. You were talking a little bit about that you didn't need it. What do you say to your friends now that you now know that you were cancerous? Are you glad that you went and had this checked up?
Yeah, because I might not be here.
Yeah. How often do we hear this story in your offices?
A lot.
A lot?
Yeah, you know, I guess people just they hear stories about colonoscopy. Some things are unpleasant and true, but other things they hear about colonoscopy are untrue. So nobody wants to do it. Everyone's looking for an excuse not to do it. But it's important. It's important that when you decide to stop, you do stop for the right reasons.
And I think we've had some cases too where people have come in to set up their procedure and then they walked away and decided they didn't want to have it done.
Really?
And then-
Well, that
and-
was Libby.
Well, I mean, and then they show up a couple of years later with something that we could have prevented from happening all to begin with.
And Dr. Hurd and Dr. Johnston's office, they're super good about calling you and saying, you know, it's time for you to come in.
Yeah.
And then you've got to decide whether you're going to do what they tell you to do.
We'll
or
take
not.
the doctor's advice, right?
Right.
I want to ask you, how did you find the prep?
It was just something you had to go through.
See?
And,
I agree.
It didn't last but a few hours, and
Yeah.
you can stand anything for a little while.
Exactly, but you're tough. I have to say to you, I'm very impressed. Now being cancer-free, correct? How often does Libby need now to go and have that checked up if you had cancer polyps?
So if 1 year after the cancer is treated would
Right.
be your first colonoscopy, and then we would do 3 years after that, and then 5 years after that, and it would be every 5 years. And of course, at any point, that interval could change based on the findings of, you know, the most recent colonoscopy.
Let's talk a little bit about my case. You did find a polyp to
Correct.
begin with.
Correct.
And you told me it was non-cancerous.
Correct.
But yet you sent me a letter saying I don't need to come back for 5 years,
Correct.
even though I'm at a high risk.
Well, yeah, so high risk, either from a family history standpoint or people who have 1 or 2 small polyps would be a 5-year recommended. Because if you think about cancer, it takes 8 or 10 years or longer really to develop from a polyp and turn into cancer. So that interval would be fine.
What do you say to people sitting at home at 70 years of age saying, no, I don't need to do it?
Do it. Just do it.
Just do it. That's a Nike ad. I like that one.
right, that's right.
Thank you for sharing your story.
You're welcome. Thank you for having me. And thank you for good doctors.
We'll be back after this short break.
Gastroenterology Associates of Columbus and Starkville is here to help. From needs as simple as a routine colon cancer screening to the most severe gastrointestinal disorders, our board-certified gastroenterologists want patients to be informed decision makers and fully understand any health issues they may face. When you choose Gastroenterology Associates, you're working with professionals who are qualified, experienced, and caring. Call our offices today for an appointment or visit our website, gac-ms.com.
Stage of diagnosis. According to the American Cancer Society, 39% of colon and rectal cancer patients are diagnosed with localized stage disease. 35% of colon and rectal cancer patients are diagnosed with regional stage disease. 21% of colon and rectal cancer patients are diagnosed with distant stage disease. Welcome back to a special presentation of On the Beat. I'm Troy Thompson. Colorectal cancer has become a reality for many people younger than the age of 50, and it's the only group where incidences are on the rise. In fact, 11% of colon cancer diagnoses and 18% of rectal cancer diagnoses occur in those under 50. That's why we need to educate ourselves about the risks of the disease now. And again, joining me in the studio is Dr. Richard Hurd and Dr. Ricky Johnston from the Gastroenterology Associates of Columbus. Thank you for staying with me today.
Thank you.
Educate ourselves. We're talking in detail now about the younger population. Why is it so important?
One is it's got it all bewildered. We have no idea why the risk is rising in young people. As you said when we opened the show, the incidence of colon cancer overall has declined dramatically in the last decade or two, and that's good. That means we're making an impact in our screening and prevention efforts at people who are age 50 and older. What we've seen in the last 10 years or so is there's a really increasing incidence in young people. Now, overall, that rate is still low, but it's still the rate is rising, and we don't really know why that is.
I want to put something out there, if I may, and you could give me your professional opinion. Is it because younger people are more aware of these issues for their family and they're being diagnosed earlier or going in for checkups?
No, they've done a lot of studies looking into that, and I don't think that really bears out in the data. Gosh, you could come up with any number of theories. Are we preventing their parents from getting colon cancer so they don't know that they're at risk, and is that why it's happening earlier? The important thing here is, again, our guidelines are lagging behind in catching up to this new phenomenon of younger colon cancer. So, young people, if you have symptoms, come in. We've harped a lot on don't wait until you have symptoms, but if you're young, we don't have screening guidelines for you. So when you have symptoms, come.
And also be aware of your family history, because some people are just not aware, and make sure that they discuss that with their physician, because if they have a family history, they need to know that, and they need to talk to their doctor about it, and their doctor hopefully would then suggest to them, you do need to get this done earlier.
Okay, well, we just touched on educating yourself,
Right.
because realistically, it is you that is going to be the one to make those appointments. Do you see a shift between men and women making these appointments, or is it still high for men being diagnosed?
No, I mean, it's the same in people making appointments. I mean, some people might consider that men are more hesitant to schedule their colonoscopy for a lot of reasons, and that may be the truth. But did I answer that question correctly?
Perfect.
And we see a lot of wives who will come in to get theirs done just so that their husband will come after them. They make kind of a deal. If the wife gets it done, then the husband will come in after that.
Okay, I want to ask you about a conversation that people don't like to hear is what are the success rates? We find out about we've got cancer, colon cancer. The success rates of a cure.
It depends on when you catch it.
Right.
If you catch it early, like Miss Libby earlier, cure rate is everybody. You know, I mean, you remove the polyp with cancer in it. That's the earliest stage you can catch it. If you catch it before it spreads and you have surgery, that's curable. And even after it moves outside of the colon just a little bit, it can still be cured with chemotherapy. But if you get distant spread, and that happens over time, then that's where you're really in trouble, and your survival rate is not good at all.
So when we say distant spread, you mean now outside of the colon?
Correct. And the first place we usually see it spread to is the liver, just because that's the natural flow of blood,
Right.
you know, from the intestinal tract back through the liver. So that's usually the first spot that we'll see lesions develop from the primary.
When you talked about Miss Libby before finding a mass of polyps, correct, that were cancerous, how soon are we getting those results back from the clinic to know what is going on?
Yeah, if you're doing a colonoscopy and you see a mass in the colon, you have a bad feeling about that. You generally know then that that's what you're dealing with. But we take biopsies, we send them off, and 1 or 2 days later we get the results back to officially confirm if it's cancer.
What's the next step
As far as
after you get the diagnosis?
for colon cancer, well, it depends on the stage generally, or we would refer them to a surgeon. Maybe get some imaging done. Sometimes we'll do a CT scan, because that might dictate the sequence in which you do things. Generally, you know, surgery is going to be your primary way to cure this, but if you've already seen spread outside of the colon, then surgery becomes less of an option unless there's, you know, an obstruction or something pending. So then you might do chemotherapy first. So generally we're going to refer to a surgeon and an oncologist at the same time.
Let's say surgery. That is removing parts of the colon, correct?
Oh yeah.
And how much are you removing at a time?
It depends on where in your colon this is as to what you have, but just the smallest section possible to get that out of there.
I understand. I just want to talk about your practice, if I may, in a moment. Being a patient there myself, I have to say I was totally impressed with your team, the level of professionalism. How long have you all been there now?
I've been there for about 10 years, 10 and a half years now total.
I've been there for 5 years.
What?
I'm the newest.
You're the newest, you're the new kid
He's
on the block.
Our newbie.
On average, how many colonoscopies are you doing a day?
The days we perform procedures, which is usually 3 to 4 days a week, probably 6 or 8, and then we do some upper endoscopies along with that. But colonoscopy is probably 6 or 8 a day.
But the whole clinic, I mean,
Yeah.
we'll
Yeah.
do 40
That's each.
Yeah,
Right.
yeah.
And we have 5. There's 5 of
Yes.
us.
We'll do 40 scope procedures a day.
Yeah.
Sometimes.
Incredible. Well, I just want to say thank you for looking after me.
Happy to.
You took a great weight off my shoulders, and I appreciate it. Thank you so much
You're
for
welcome.
all the information and education that you've shown all of our viewers as well. If you want to find out more information, there it all is up on the screen. And remember, everyone, prevention is key. We truly appreciate you joining us today on what is a very special presentation of On the Beat.